Hello everyone, my name's Andrew. I'm the Immunisation Fellow at the National Centre for Immunisation Research and Surveillance based out of the Children's Hospital at Westmead. Today I'm going to talk to you about shoulder injury related to vaccine administration, which is known as SIRVA. SIRVA is a shoulder injury that's related to vaccine administration, which is described in the literature as occurring when there's the unintentional injection of antigenic material in the synovial tissue, resulting in an inflammatory reaction. It's a rare complication of the incorrect vaccine administration, and it boils down to placing a vaccine where it shouldn't otherwise be. It can be described as a multitude of symptoms, including bursitis, tendinitis, so irritation of either the bursa capsule or the tendons around the muscles of the shoulder, rotator cuff tears, so tears in the actual muscles that control the movement of your shoulder, and fluid accumulation around these structures where you wouldn't otherwise expect fluid. But it can also be much more serious injuries, including injuries to the bone and the periosteal layer of the bone, as well as there's been a few cases online of osteonecrosis of the humerus itself, which is much more devastating to the shoulder, obviously. So how common is this? So in 2020, we've had 5 cases so far this year, and I've previously found cases from the SafeVic database in Victoria from 2007 to 2016, looking at about eight cases, but comparing the SafeVic figures to the New South Wales figures, one might think that it's been underreported. This table is a bit small, but really is just here to show that out of the SafeVic data that we've got, it really is independent of any particular type of vaccine. So it can be the flu vaccine, it could be a DTPA Boostrix vaccine, it can be Gardasil as well. So really it doesn't seem to particularly matter which vaccine it is, but if you place the vaccine in the wrong place, you're likely to cause injury that you wouldn't have otherwise desired. This is that super rare event I was showing you. That this is a case study regarding someone who was giving an influenza vaccine. It was given a little bit too high, and what resulted was actual osteonecrosis of the femoral head, of the humeral head, I should say. And as you can see in this MRI, there's some signal irregularity in the cortex of the humerus, which is suggesting that the blood supply has been compromised. So just refreshing our anatomical landmarks of the shoulder. Obviously in immunizations, we want to administer these vaccines into the deltoid muscle itself. But as you can see, in the upper segment of the deltoid muscle, there is a bursa below it. And this is a nice fluid-filled sac that should facilitate smooth movement of the shoulder joint and provide frictionless movement of the deltoid muscle with the rotator cuffs below it and the humeral head. What we should also look out for is structures that are coming off the humeral head near where we're injecting. So in this slide, we're looking at the teres minor muscle, which is involved in externally rotating your arm. As you can see on this slide, the teres minor inserts just at the humeral head there, and then across to the scapula. And the actual insertion point on the humerus is marked there with an X on that lady's shoulder. So hopefully you're all thinking straight away that X was a bit too high for where a vaccine would be administered. So why do we inject where we do? So there was a good study in 2011 by Ian Cook, and this was looking at 536 patients and what the most accurate way to deliver a vaccine without causing injury to these surrounding structures. And this was published in the Journal of Human Vaccines. And what they really did was try to map exactly where all these potential structures were in the shoulder, and therefore find the most predictable way to to easily assess where to put a needle without causing injury to any of these. So what they found was, after assessing multiple different techniques that were available at the time, that the injection midpoint of the muscle, by gauging the head of the acromion, which is that bony bit above your shoulder, and the deltoid tuberosity, which is that V-shaped bottom of the deltoid muscle, finding the exact midpoint to that was probably the most accurate way to miss all these other structures. Incidentally, this paper also suggests that abduction of the shoulder to 60 degrees can move the anterior branch of the axillary nerve proximally, and it can move it by about 1.3 to 1.4 centimeters. So that's not insignificant. So whilst this axillary nerve might be only responsible for some of the innervation of the deltoid and the overlying skin, it's still important to not intentionally cause, or even accidentally avoid causing injury to this structure as well. So this paper is suggesting that we should inject all our vaccines with the shoulder abducted 60 degrees, which interestingly is something I don't see done very often. So boiling down to the recommended vaccine technique, and this is also highlighted in the immunisation handbook, if everyone wants a refresher. So what we're suggesting is exposing the arm completely from the top of the shoulder to the elbow, removing any shirt or clothing. So really, no one should be rushing to give a vaccine. So this allows you to locate the landmarks. So the head of the acromion, which is again that bony point at the top of the shoulder. And then you're feeling for where the muscle bulk of the deltoid kind of peters out halfway down the arm. And if you can draw an imaginary inverted triangle below the shoulder tip, and using the axilla or the armpit as the like maximum cutoff for that horizontal line, that should mark a clear area where you can deliver a vaccine without hitting surrounding structures. Quite often we are delivering more than one vaccine at a time, and this is recommended for children for 12 months of age or older, that we would give all the vaccines now in the upper limb. And again, this is to minimize damage to surrounding structures as well as the delivery of the vaccine into fat, which is suboptimal, and I'll talk about that in the next slide. So if we're giving 2 vaccines at a time, we would still want to give it within that window. And you can separate each vaccine by about 2.5 centimeters and deliver them both in the deltoid muscle. And this would allow you to give 4 vaccines in the upper limbs without any risk of, or potentially minimizing your risk of hitting any surrounding structures. So just a bit of revision regarding the importance of the depth of your needle. So this similar study, the same study by Cook, demonstrated that there also looked at the depth of the needle that was required, and this should be a refresher to everyone, that ultimately we do not want most vaccines to be delivered into the subcutaneous fat layer or intradermal. Obviously there's some exceptions to this, but the vast majority of vaccines we want in the muscle. And the reason for that is the muscle has a much more rich blood supply, and it mounts a very predictable immune response with minimal subcutaneous abscesses and nodules being formed. Once you start delivering vaccines in the subcutaneous fat, the blood supply is not so much, or not as rich, so therefore you have more immune cells that linger around in this area, and more likely chance of mounting a localized immune response to this vaccine. This then can perpetuate into a subcutaneous nodule and eventually potentially a sterile abscess that comes to the surface. So this is one of the reasons we recommend that children over 12 months of age and over do no longer receive their vaccines into their thighs, as there is a lot of fat in that area. And what we want to make sure is that these vaccines are actually delivered into muscle. So again, making sure that you deliver your vaccines into the deltoid muscle itself. So Cook's study looked at the 25 millimeter long needle inserted right up to the hub at 90 degrees. It gets about 5 millimeters into the deltoid muscle itself. So if you really think about it, you're not talking about a huge margin of error here. And Cook found that this was consistent for males under 118 kilograms and with a BMI of under 35. and for females 60 to 90 kilos with a BMI under 35 as well. So there was a risk of underpenetration for individuals over these BMIs or over these weights, because obviously they have more fat overlying their deltoid muscle. But interestingly, they also noted that females under 60 kilograms, there was a risk of going through the deltoid muscle on the other side and potentially causing a periosteal injury. So obviously when you're giving an injection, if you hit bone, you should withdraw at least 5 millimeters to very much clear that periosteal area before administering a vaccine, and then reconsider your needle size in that particular individual. So the take-home messages from today are that make sure that you can visualize the deltoid muscle in its entirety from the shoulder to the elbow when you're giving a vaccine, and make sure you're not rushed in this approach. Be familiar with your anatomical landmarks and surrounding structures, and follow the recommended immunization administration techniques set out in the immunization handbook, which boil down to aiming for the middle of the deltoid. So remember, feeling the lower deltoid tuberosity and then the upper acromion head and finding your midpoint, and you can even draw that imaginary inverted triangle. And make sure you do not inject too high or too low, because you risk damaging surrounding structures, and this can be quite debilitating to the patient. And finally, please be aware of your needle depth, especially in overweight or slender individuals.